geared towards those health professionals who might not have as much clinical training in behavioral health. So it's going to be a great session. I also see, though, there's a great turnout, you guys, today. And for those who might be interested in joining us for the Adolescent Health Initiative certificate piece of this, you can still join. And Michelle's email is going to be at the end of our slide set today. And so if you'd like to just reach out to her, we can give you guys some more information on that process. And it's relatively easy and simple to complete. So we welcome everyone. But for those of you who perhaps are not enrolled in our certificate program, you will absolutely receive CME for each one of our sessions. So before I introduce today's presenter, we'll go around the room and we'll let you guys know who's here with us in the Envision Studios.
Hi, my name is Maya Trujillo. I'm with Envision New Mexico. I'm a quality improvement specialist.
Kirsten Bennett, dietitian here at Envision.
I'm Ross Newman. I'm a pediatric resident at UNM.
Excellent. Well, let's get started for today's talk. I'd like to introduce to you Brian Isaacson. He's an associate professor and clinical psychologist in the Department of Psychiatry. And today's talk is focusing on trauma-informed care. Basically, how to build a more trauma-informed service system for a broad spectrum of health providers and a broad spectrum of systems, school-based, hospital-based, etc. So we're very excited to have Brian here, and with that, we'll turn it over to him and we can get started.
Well, thank you. I'm very happy to be presenting today on this topic, and grateful that I was invited. And so like I was introduced, I'm a clinical psychologist here at the University of New Mexico in the Department of Psychiatry, and a lot of my work, clinical and research, is around trauma and the impact of trauma and how to build a better system so that our children and adults are better served in the service system. And so I'm very happy to see the list of all the people on the call today who are from a broad range of professions and settings. So, which is important for this kind of presentations. It's not just about how to do work with a child who's experienced trauma, it's how to support them to do well in the system. So whether that's juvenile justice or schools or a pediatrics clinic, this all applies. And so as I present, I want you to reflect on your own setting and how these things could improve your setting and the work you do, and how your clinic can be more trauma informed, and also be thinking about what the strengths are of your setting as well, because I'm sure there's a lot of good work already being done in those settings, and we can talk about that at the end when we have a discussion. And so here's just an outline, and as I go through the slides, I'm not necessarily going to cover every point in every slide, but it's there for you to see, and I probably have a few more slides than I need in here so that you can see it, but we want to make sure we have time for discussion. But we're going to talk about, we're not going to specifically talk about what a diagnosis of PTSD is or anything. It's that's a presentation for another day, but we're really talking about the system of care that we provide our services in and how we can be more trauma informed. And so just a quick example of trauma informed, non-trauma informed. Let's say a child discloses abuse in school maybe to a teacher, and the family is sent to CPS or Child Protective Services for an interview or to a medical exam and to a therapist without much information. They're just sent there with all new people, not really told what is happening or who is asked, who knows what. You have to repeat the same story every time, and that can be really traumatizing for a child to have to tell the story over and over. And that would be a non-trauma informed system, but a trauma informed system would be one where maybe a child discloses the abuse, the school explains what they need to do, and they call Child Protective Services with the child and family, and the school social work assists going through the meeting with Child Protective Services, and then once the Child Protective Service worker is involved, they maybe accompany the child to the medical exam. And then share information. They get the release of information so the providers have the background, the story of the trauma, and so the child didn't have to repeat the whole story over and over again. And then each step of the way explaining what's going to be done, why to the child, why this is happening, why you would have to go to a medical exam, or why you'd have to go to a therapist. So all parties who come in contact with the child and the family communicate and understand their role in supporting the family and partner together. And so just briefly, some definitions that I like. This is the DSM-5 came out just a year or two ago, and this is their definition of trauma. A person experienced, witnessed, or was confronted with an event or events that involved actual or threatened death, serious injury, or threat to the physical integrity of self and others. And so that's a pretty common definition. But I really like to stress throughout all of this the importance of resiliency and recovery. And so it's important to recognize that actually most children who experience trauma do fine and they bounce back, even though they've had a difficult experience. But usually the kids who come into our service systems aren't doing as well. So a lot of times we forget about the hundreds of children who've experienced bad events, whether it be child abuse or an accident or a natural disaster, who bounce back and have a good support system around them. And so people who experience trauma can live full and productive lives after it happened, and that can be in a variety of ways with different supports. And so, and it's also important to recognize, and we'll talk about this a little bit, but it's also, it's really a positive approach that we're talking about, where we feel the family can function well and thrive after this. And so you may have seen some numbers recently on the impact of child maltreatment. It's a huge cost to our society, and of course, finances aren't the major impact of child abuse, but it's something it's a language that legislators can understand, and we can really show the impact on our community and society when we have ongoing child abuse. And so you can see there's national data and New Mexico data here. And so avoiding one case of child abuse or neglect saves the state about $100,000. And so I really like to stress the importance of prevention, and that can be preventing child abuse from ever happening or child maltreatment from ever happening, or it could be preventing ongoing child maltreatment. So a trauma-informed system will recognize trauma when it's happening and be aware of it, so that they can get the supports around the child and family so that it's not an ongoing experience. And so one thing that I think is really important is that many survivors of trauma don't seek services specifically to address trauma. So they're going to come into our clinics, our schools, our different service systems, and they don't say, I'm coming here because I've experienced trauma. They may say they're having, depression, or they're not functioning as well, or they have back pain or whatever, or some kind of medical condition. And so many people who experience trauma can often be misdiagnosed, especially children. If trauma isn't identified from the get-go, they may be misdiagnosed as having ADHD or oppositional defiant disorder, or conduct disorder, bipolar disorder, and it can be a while before, if the child doesn't disclose, or the service system doesn't know that there's trauma involved, it may be a while for that to come out, and it can be treating a disorder that's really that's just a piece of the puzzle, but not really getting at the heart of the problem, which is the trauma. And so a lot of people who come into our service systems, we don't realize that trauma is often the central problem of what they're coming in for, that's impacting a wide variety of their challenges. And so there's a new disorder diagnosis they're trying to put in hopefully the next DSM, which is developmental trauma disorder. So it's kind of capturing what happens when a child experiences ongoing maltreatment and has disruption in attachment and emotional regulation, And so a lot of these misdiagnoses that kind of capture a bit and piece of what trauma looks like in the child, but this diagnosis will kind of put that all in one diagnosis. So that's promising. And so, like I said, we're going to focus more on the trauma-informed system of care. So it's a system it's one in which all components of a given service system have been reconsidered and evaluated in the light of a basic understanding of the role that violence plays in the lives of people seeking mental health and addiction services. And I would broaden that to not just people seeking mental health and addiction services, but it could be in any service system, whether that be juvenile justice, primary care, education, child welfare, and even first responders. And so we can reconsider how we do our services based on the understanding that many people who we come in contact with in those settings have experienced trauma, and we need to be aware of that. And so this is different than what we call trauma-specific treatments or interventions. And we'll get to that later, but that's more of maybe a specific type of therapy or medication to address the trauma by a specialized provider, whether it be trauma-focused cognitive behavioral therapy or prolonged exposure therapy. So that's a very specific service within a trauma-informed service system. And here's some other definitions of a trauma-informed system of care. There needs to be this understanding, commitment, and practice organized around the goal of successfully addressing trauma-based needs for those receiving services. And then it's very important also, especially in a state like New Mexico, to recognize the historical and intergenerational trauma influences. And so there can be ongoing trauma intergenerationally, but there can also be a historical trauma where generations of trauma impact families and children, even if they haven't experienced the same trauma that maybe a few generations ago, but it stays within their community and can be harmful. And of course, and I also like to stress the importance of intergenerational resilience and having strengths within a community that can, even with ongoing trauma or repression, there are strengths that can support a family as well. But it's just really important to understand how cultural practices can direct these interventions and these settings. And of course, that's a large topic for another presentation, but it's something that in any trauma-informed system, you would need to evaluate what cultural practices there are in the community or cultural backgrounds, and how we need to adapt a system to support those from those cultures. And so in the trauma-informed system of care, it's not just the providers, not just the primary care docs or the psychologists or the social workers. It can be anyone who comes in contact with the child. So it could be the custodian at the school or a school lunch worker. They can all be aware of the impact of trauma. For example, if a child's been in a car accident and there was a loud crash, being in a loud lunchroom may be overstimulating, and a child may act out or become scared. And so a lunchroom worker may notice a child responding that maybe a teacher wouldn't. And so it's helpful if anyone in the system understands how trauma impacts the child. So I won't spend too much time on this, but this is just some basic definitions. And so, the last point of the service relationship is really important, and this is what we'll spend a lot of the time on. There needs to be trust and safety. It has to be earned and demonstrated over time, and there has to be a sense of partnership and focus on strengths. And so why would we want to create a trauma-informed system? We want to increase public awareness about the impact of trauma. We want to build these partnerships to address this as a community. Promote, and like I mentioned before, promote wellness, resiliency, and protective factors. And these protective factors are very important for a community. So these are things that can be in place before a trauma ever happens, that when someone experiences trauma, these things are in place and can buffer the impact of trauma. And these things could be some, for example, like access to resources, social support, healthy attachment, self-efficacy, emotional regulation. So all these things are protective factors that if there's a child has that in place or has that support, they're going to do better after experiencing a trauma. And when we're better able to identify individuals that experience trauma and we understand a person's responses to trauma, and we can quickly get them into services when we're aware of that. And so I work a lot at UNM where we have in the psychiatry department, we have programs for children in the Children's Psychiatric Hospital, and there's just such high rates of trauma in this population that come to us that we work under the assumption that a child may have experienced trauma. So we always, and we'll get into universal screening, but we always ask about trauma. We try to make it common language so it's not something to be scared of or to shy away from, and we train people to be ready to talk about it. And when we have a trauma-informed system, we avoid re-traumatization, and I'll talk more about some ideas for that. And very important is when we have these systems in place and we're trauma aware, we also look out for our staff, and then this helps decrease staff burnout and improve the services we give. And so these values of trauma-informed system care, power, control are vested in the service user. So it's very important that the consumer or the family or the child feels like they're part of the treatment team and invested in making decisions about their services and their care. And it's really our responsibility as a service team to provide psychoeducation on trauma and its consequences. And so we have to be well informed so that we can explain to a family what trauma is and why it's impacting their family. And so we want to promote a safer environment and a healthier, more balanced life. And that again goes for the family as well as the provider or the staff. And we want to avoid jargon, blaming the victim. We want to show respect in our work. And these values are really important because unless a family's court ordered to be at a certain treatment facility, they're going to show by their feet whether they feel like it's a safe environment. They're not going to show up. And so it's really important to have these things in place ahead of time and to be aware of them and continue to try to improve a service system. And so, again, this is some more definitions. I'm not going to spend much time on this again, but there can be a lot of chaos in a family. And so we need to be aware of how trauma is currently impacting a family. There may be ongoing trauma or ongoing abuse. And so that can be a real challenge when we want to help a child, but they're in an unsafe environment, whether that be a neighborhood or a family. And so we have to realize the challenges of that come with that. And so with this kind of being trauma-informed, it's really a place to instill hope for recovery and healing, that people can do better, and we expect them to improve. And I do a lot of work with refugees who have resettled here in Albuquerque, and I meet with them usually within the first year of them getting here, and they're so overwhelmed because of past trauma, but because of current stressors of living in poverty and not understanding the language and culture. And I really think one of the things that I bring is I instill hope in them that life will get better, and that I can help them have a vision of the path out of the challenging times they're in, and they can hold on to that. And that's something we can do in our trauma-informed care as well. And then another real important part is we can talk to families about their beliefs about trauma and the needing to talk about it. Some people don't want to talk about it. Some people don't want to do a big, long narrative exposure therapy where they tell their story multiple times. Some people feel that's really important. So really understanding their values and their need or want to talk about it or not talk about it, and then adapting services based on that. And so I'm going to spend some time talking about these domains of a trauma-informed system of care. And so as we go through this, I want you to be thinking about your service system and how you can maybe apply some of these things in your setting. And so the first one is program procedures and settings, and we'll talk about these 5 areas. So the first one is establishing and assuring safety. So to what extent, oh, sorry, here we go. Sorry, so here's the 5 we're going to be going over. And the first one is establishing, ensuring safety. To what extent do the program's activities and settings ensure the physical and emotional safety of clients and staff? And throughout all these, it applies to clients and staff, because if we don't have a healthy staff, it can lead to burnout and a lower quality of services. So we want to create an atmosphere that provides safety and acceptance. We want to make sure that our settings don't re-traumatize a family. And so that could be magazines or pictures on the wall. It can also be what discussions there are in the lobby. You know, we have to have strict confidentiality. And this can be on elevators or in hallways. One thing that I try to recommend is not just being really careful about those conversations, no matter who's listening, because if a family overhears you talking about another family in the elevator or hallway or the waiting room, they may assume that you're going to be talking about them in a more public setting. And so just being really careful about that, so that they know that when they come to whatever service system you're in, that it's going to be a safe environment. And also another way you can think about how to use space differently. And I worked with a veterans program out in Rio Rancho that was at with Presbyterian Medical Services, and it was in a really busy primary care clinic, and they were serving a lot of veterans. They actually had a separate entrance that veterans could come to that was a more quiet setting, so they weren't overstimulated, and that really helped the veterans feel comfortable being in that setting. And the next is trustworthiness. So maximizing trustworthiness through clarity in task, consistency, transparency, and interpersonal boundaries. A lot of families who have experienced trauma are mistrustful of other people because they've been victimized. And so they need to come into a setting where they know what services they're going to get. They know that the people who agree to do provide services are going to follow through. And so it's very important to be transparent about what you can and can't do, be transparent about the limits of confidentiality, especially when it gets involved in legal settings. And we already talked about respecting culture and race and ethnicity. All these things are so important that are very important to a person's identity. If they come into a setting and feel like they're not being respected, or they're an outlier, they may not feel comfortable coming back. And so that, that could be having a wide variety of posters on the wall or magazines with people of all different backgrounds. And so part of this trustworthiness with staff then is ensuring that supervisors and administrators can be trusted to listen respectfully to their staff's concerns. Staff burnout a lot of times isn't so much that for let's say a therapist who does a lot of trauma work, it's not so much that they get burnout just from hearing these stories and doing this work. It's that they don't have the support of their supervisors and administrators to help maybe shift a schedule or think about a different variety of tasks to do. And so if they feel like they're not ever to be able to give feedback that's listened to and addressed, then that's what can really lead to burnout. And choice, this is really important. To what extent do the program's activities and settings maximize an individual's experiences of choice and control? And like I said, trauma survivors have had a lot of times a loss of control and choice through their traumatic experience, whether that be child abuse or a car accident. And so it's really important for them to feel that being empowered to make choices for themselves. And and to choose not to have certain services at that time as well until they feel comfortable with that. And so they can have choices in the services they receive, the providers, their goals, the length of sessions. I've worked with refugees who could, have very short sessions, like a very traumatized. I'm thinking of one in particular, a woman from Iraq who's very traumatized, could really only handle maybe 20 minutes with me, and sometimes she just stand up and leave without saying anything. And for me, I was like, oh, what am I doing here? How am I even helping? But I was there consistently, giving her that choice to leave and not make her feel bad about it, or not say, well, I can't work with you. I just consistently was there, helping, letting her decide how long we're going to meet for, what services we're going to be doing, what our goals were. And I've worked with her for a few years now, and she's doing much better. And not necessarily because of me, but she's still with me because I think I gave her those choices. And the same goes with staff, allowing them to provide feedback about changes and about what their role is and what they best see as how they can best serve the population in the clinic they're working in. And then collaboration. I talked about this a little bit already, but to what extent did the program's activities and settings maximize collaboration and sharing of power between staff and individuals receiving services? So this could be having a plan to prevent re-traumatization, so understanding what their triggers are and trying to avoid those, and having influence on, like having a community advisory board where they can give feedback on what it's like to go to your clinic or your setting. And then again, with staff, having a more flattened hierarchy where the staff are able to impact the setting and make choices. Since they're the frontline staff, they can really tell you what's going on at the ground level. And then empowerment, we talked about this already too a little bit, but to what extent do the program's activities and settings prioritize individuals' empowerment, growth, and strengths? And so we want to convey a sense of hope and optimism, like I talked about. And we want to really expand a person's resources and social network so they become less and less reliant on professional services. And so helping them tap into existing natural resources and services and help so they can do those things for themselves and be less reliant on us. And then again with staff, having a sense of responsibility by staff for the quality of care can really lead to a lot of good changes and growth, especially when there's a breakdown in the system, because they feel responsible and they feel dedicated to the setting where they can really make the improvements. And we'll talk briefly about formal service system policies. And so this may have to do with formal policies like confidentiality and access to information, understanding those rights really clearly. And another important part is a formal policy around de-escalation to avoid re-traumatization. So being really clear up front about what to do when someone becomes overwhelmed emotionally or even combative, and helping them even build that into a treatment plan so that they know what is expected of them and what is expected of the providing team. And so the other formal policies can be respecting advanced directives, having quiet spaces available, having a high ratio of staff to service users, and so forth. And so the next one is trauma screening and assessment and service planning. And so we really push to have all adults and children who enter a healthcare system to be screened for trauma. And so this can be very brief, and I'll give you an example on the next slide, I believe. But we really want to just, be upfront that we, I know I've done a lot of training for like pediatricians and other medical providers to understand that it's okay to ask about trauma, and people actually appreciate being asked. They may not want to go into a lot of detail, but it's comforting to know that their provider is thinking about the whole person and not just a specific physical or medical condition. And survivors may not report trauma immediately, and so it's important to keep in the back of your mind that even though they're not telling you, they may deny and not endorse anything on the screen, but they may have experienced trauma. And so it's important to use the best tools available for your setting. And then if they do on a screen identify trauma, then you can do a longer trauma assessment and look at symptoms, the full range of symptoms, and identify triggers and stressors and strengths and coping skills that you can build into a treatment plan. And also a specific diagnosis isn't as important as understanding the role of trauma in a person's life. So a person could get diagnosed with a personality disorder or PTSD or depression or substance abuse, and these are all things that are a lot of times outcomes of trauma, but the diagnosis isn't as important as understanding what the person is experiencing. And so here's an example of a screener that we use I'm the principal investigator on a grant from SAMHSA with the National Child Traumatic Stress Network. It's called the Action Clinic here at UNM. And we work with anyone in the Albuquerque area to provide direct trauma care to children 5 to 18 who've experienced trauma. And so this is when we get referrals, we ask the provider to complete this checklist. And so you can see here it has 8 different types of traumatic events and the age when it happened, and 4 simple questions that are related to PTSD. And so this really just gets the discussion started and allows a referral. And so we're working with some settings to actually do this in like a school-based health center or a primary care clinic to do this as part of their intake, so that they can know what a child is experiencing, and then they can start moving forward with addressing the trauma if it's appropriate. And again, this is just a snapshot. It gets the discussion started. And so for me, I think the discussion that comes out of this is more important than checking any box. And so some settings may not have this available or may not feel comfortable using a checklist, but they can ask about it and talk about it and try to get a sense if a further assessment is needed. And then I mentioned trauma-specific services. And so these are services that, if they're warranted and the individual agrees, you actually provide trauma-specific services to address the trauma. And so these can be practices such as trauma-focused cognitive behavioral therapy, prolonged exposure therapy, seeking safety. These are all trauma evidence-based practices developed to address trauma specifically, and they can be very useful at certain settings, certain times, but these exposure-based therapies may not be the best fit for all individuals, so really trying to find out where they are and what they want to address. And you can address trauma without doing a narrative or exposure therapy at that time. You can address attachment relationships, you can address emotional regulation, coping skills, parenting techniques. All these things help support a child who's experienced trauma. And then creating a safe space to address the trauma is important. So establishing a caring relationship, all these non-specific therapeutic aspects to therapy that we've talked about over and over in our training. Addressing barriers that limit treatment engagement. It could be having a Saturday clinic or an evening clinic where families can get in, or having a playroom available for if a parent has to bring in other kids. And I really stress the importance of not pushing the individual to discussing their trauma history in detail. You can build up to that to when they're ready for it, so that they understand that it's a safe space to talk about it. And then we're going to talk about administrative support. So using feedback to make recommendations that support the integration of knowledge about trauma and recovery into all program practices. So you can have a policy statement for your clinic. I worked with the state of New Mexico to develop a state policy statement on trauma-informed care and that can shape and inform service providers throughout the state. And so that's a formal policy statement that infuses some of these principles you've talked about today and kind of give guidance to what that service system can look like. And I already mentioned working with the community advisory group that can really give feedback about your clinic or your setting and how trauma informed it is. In staff training and education, it's really important that, I mentioned this before, but anyone who comes in contact with a child or a family should be educated on trauma and be sensitive to trauma-related dynamics and be able to avoid re-traumatization. And so it can make a huge difference, even if in a clinic at your frontline staff who checks people in. If you have someone who's very supportive and friendly and welcoming each time a family comes in versus someone who doesn't make eye contact or is short, or can hear gossiping going on, really makes a difference for having someone feel comfortable. And so so having all staff understanding the impact of trauma, and also it's important to train non-providers, like I mentioned, so law enforcement, school, clergy, anyone who has interaction with the child can be more trauma informed. And then finally, human resource practices. So trying to hire or identify current staff who are trauma champions, who are knowledgeable about trauma, who can communicate with others, can help provide training, can make support changes within a system. And you can even consider asking questions if you're in a setting where there's a lot of people who have experienced trauma. In your interviews, ask about their experience of working with trauma survivors, what they know about the impact of trauma, so that they, coming in, you can get people who are geared up for it. And you can also, if you have the opportunity to provide incentives or bonuses for people who take on a role to promote trauma-related activities, it can be helpful as well. And then staff care is really important. So setting up an environment where there's task variety. So for example, we have our trauma clinic, so we only accept children who experience trauma. And so we have clinicians working full time, but we try to mix up their tasks, even though it's with the same population. So we have a lot of training opportunities for them. They supervise interns and psychiatry fellows, and we have them get out of the clinic and do other activities. But also it's really important to have an environment where people can feel they can talk openly behind closed doors in a confidential setting, so that others don't hear, but the impact of what it's like to work with trauma survivors and the toll it takes emotionally. And then having an environment where they can talk to a supervisor or an administrator that they need some support or need a change of tasks to support their well-being. And I would also say encouraging staff to actually use their days off. Some staff build up, especially here at UNM, build up months and months of days off, and we need to encourage them to take vacations and enjoy life outside of work. And so, in conclusion, trauma is pervasive. Like I mentioned, there are many outcomes, from resiliency to not being affected by it to having some serious functioning challenges. But we can build a system, we can build strengths and adjust the system to help the survivors of trauma so they can thrive in these settings. And we can promote wellness and resiliency and protective factors. And we can infuse safety, trustworthiness, choice, collaboration, and empowerment into our settings so that these children and families thrive, even though they've experienced some difficult things. And then here are a few references from the presentation, but there's a lot out there. There's some great websites and a lot of books and articles. I encourage you to look at those. So I guess now is the time for, well, where did I go here? Time for questions or comments. So I'm curious, as we discuss this, what are some things that we've talked about today that you might want to implement in your setting? And what has worked in your setting, or what questions do you need for clarification?
I have a question. I'm wondering, what are some trainings you can do with staff, maybe in a school, or even like a juvenile justice setting, that can lead to a more trauma-informed lens of how they see their students and how they can work with them? Is there any specific trainings that you're aware of?
So one great resource is the National Child Traumatic Stress Network. So the website is nctsn.org.
Oh yeah, is that Bruce Perry's? Okay.
It is not actually. That's a great group too, but this is from a SAMHSA funded group, and
Oh, okay, great, thank you.
there are tons of resources for any kind of setting, whether like how to talk to judges about trauma or teachers. But I would say for non-providers who don't have a background in understanding trauma, doing like a trauma 101 training for over a lunch break or a staff meeting to just explain, this is what trauma is, this is how it affects kids. These are some of the things you may see in a school setting, where from a kid who's experienced trauma, maybe isolation or being overwhelmed by loud sounds, some of these triggers that are reminders, and then what you can do when you've heard about trauma, or especially training on if a child is disclosing child abuse or maltreatment for the first time, helping them understand that they're mandated reporter, understand the process so it's not scary and overwhelming. Because that can, for non-providers, that can be a very scary situation to have a child disclose trauma and not know what to do about it.
Yeah, great question.
Thank you.
Felicia has a question. Hi, Brian. Having worked at the Southeast Heights Clinic with refugees for several years, I always struggle with how much to delve into trauma in the primary care setting, especially when kids and teens seem like they were doing okay, ? What are your thoughts? Do you have a couple of favorite screening questions to use?
So, that's good. So I worked with Felicia there a little bit. So working with refugees, this question really isn't specific to refugees. It's really in primary care. What do you do as a primary care provider when you have to do a lot of other things if it's a well child visit or something? How do you address trauma in addition to the 10 other things you do in the 20-minute visit? And so we actually have worked with Young Children's Health Center here at UNM, and we came up with 3 questions to ask. So we have them do this at well child visits, and they have already done a little screen before about not just about trauma, but about kind of like current stressors. Do you have enough food? Do you have adequate housing? Do you know how to, the number for poison control, all these kinds of things. It's called the SEEK questionnaire. It's really brief. But then we have them ask 3 questions, and I might not say them correctly off the top of my head, but basically has anything happened to you or your child that's been really stressful since our last visit? And then second question is, are you still impacted by that, or how are you been impacted by that, and would you like to address that? And the third question is, what are some strengths? What are strengths, or what's going well for your child right now? And so we wanted to have a strengths-based approach, but surprisingly, that third question is one that had the biggest impact, because parents they weren't expecting that question. It kind of just shifted the conversation, and so they actually had to think, well, what's going well? And then if things aren't going well, then they're more likely to bring things up. And so so it wasn't necessarily asking specifically what trauma you experienced. It's allowing them to know this is a safe place you can talk about it. And we also, even before we do that, we have a little intro saying we care about your child's wellness, including physical and emotional well-being. And that's why I'm going to ask these questions, right? So they know that you care about that. And we don't necessarily expect that you're going to open up that first time, but maybe when they come back from their well child visit a year from now, they remember that, and they're going to be asked again how they're doing, and they may bring it up at that point. And so we want to have an environment where different people are asking questions in an appropriate way, so that when the person's ready to talk about their trauma, they feel comfortable doing that.
Great. Kate actually is sharing, looks like a wonderful resource. Her organization has recently put together a resource packet on ACEs and resilience with resources and tips for providers and others. Excellent. Thank you so much for sharing that. And I just had a question, you know, how do you think, when we talk about trauma, I know that the questions that you had asked were sometimes those instances that relate to a diagnosis of PTSD. How do you feel about the ACEs and screening for ACEs within primary care?
Good question. So the ACEs, the adverse childhood experiences, are asking about 10 events that happen in a child's life. And it's a longer discussion, but
Okay.
There was a study done on adults in a managed care organization. They were asked about these childhood experiences they had and then they look at how it impacted their health. So this is an epidemiological study looking back 20, 30, 40 years about how these childhood experiences impacted them. And so I think the ACEs study is great for that, understanding the impact of childhood experiences, but it was not meant as a screening tool. And so the problem with just doing the ACEs is that it puts in the same category, like were your parents divorced, it has the same level of impact as have you experienced child sexual abuse, right? And so if you're doing a good trauma assessment, you want to understand the length of trauma, how long it was going, how severe it was, and you're not going to get that from the ACEs. Right. And so the ACEs may be a place to start, but I wouldn't ever recommend having that as the end of that. And I actually think they're working on ACEs. They're working to develop it into a screening tool and getting some research behind it. But there are a lot of measures that have research behind it. So it's not. I don't think it's to the point yet where it can be used as a good screening tool
for trauma,
for current functioning current trauma. Yeah.
Okay. Yeah, no, this is very helpful. One other comment I just wanted to add, this is Jeannie, is, you know, Brian, you had mentioned this whole idea about staff burnout. And I think for myself who trains providers many times, that we don't give enough credence to the idea of secondary trauma and the fact that as providers, we hear a lot of stories, we see a lot of things, and we know, you know, high suicide rates within school-based health clinics. And so I don't think that's usually talked about enough. And so when you talked about staff burnout, we tend to think of those people who work every day in and out, but it's actually sometimes those who aren't as familiar with trauma, but then also experience it and have to talk about it, that they're not sure what to do with all of that at the end of the day. So I wanted to point that out as a highlight, that this is another thing to give permission to talk about at your agency, to set up, as you mentioned, some practices or procedures to where there's an ability to talk about what happened just from yourself as a provider, about what your reactions are when you face or work with populations that have experienced trauma. Felicia has another question. This is great, Felicia. A lot of frontline providers are encountering kids that are very fearful about possible deportation of family members, anticipating trauma. Just as many teachers are experiencing the same phenomenon. Any suggestions on how to approach this fear in the clinical setting? That's a great question.
Yeah, thanks for another tough question, Felicia. So I think that, you know, unfortunately, in our political environment right now, this is getting worse, more fear. And this is where transparency is important, and trust. We definitely can't promise anything that we can't deliver on, right? So I work with refugees from Syria who are not in a similar situation, where they hear rumors that they may be sent back to their home country, or that there's going to be hate crimes. And so I'm careful to not say, well, no, we're not going to let this happen. I won't let, you know, I can't promise that. Right. I don't have any control over, I have only influence over my sphere. So I acknowledge that that's a real fear, and then help them to manage their fear and understand how they can control their anxiety. But I also tell the families I work with, I say there are a lot of people in America who don't want that to happen and who are going to stand up and try to do their best to support immigrants or support refugees staying here. And you have a lot of people behind you who are going to support you and who are going to stand up with you. And that can be comforting. But again, you can only promise what you can promise. And so if it's in a primary care setting, saying, offering to meet with a counselor who can spend a little more time on that can be really helpful as well. And then in schools, being aware of what the kids are talking about. There can be some harmful, hurtful things said. And so encouraging teachers to have a safe environment where they don't allow kids to say harmful things about refugees or immigrants or whatever. So I hope that's helpful. That's a tough one.
It's a tough one. Yeah, absolutely. Yeah, I appreciate hearing your thoughts on this. I know it's a hard question and lots of us are struggling with it. Absolutely.
Yeah. And I would just add, for whatever, I know a lot of you are from different professions, social work, pediatrics, psychology. A lot of your professional organizations have really good resources on addressing trauma and trauma-informed care. So I know that AAP, American Academy of Pediatrics, is really doing a great job on toxic stress and understanding trauma in the system. And so look to see what is available in your professional organizations. But the National Child Traumatic Stress Network is great. International Society for Traumatic Stress Studies. There's a lot of SAMHSA resources available as well.
Excellent. Well, everyone, I wanted to say thank you, Brian. That was amazing and a very important topic. And, Brian, do you have your email or contact info? Okay.
At the very beginning.
So if anything comes up as you go through your week, we can always reach out to Brian again for that. And again, I appreciate everyone's participation. Just a reminder for those of you who, actually we want everyone, correct? Kevin?
Yes.
At the end of each of our sessions, there will be a post survey, very quick, just takes a couple seconds to answer, just based on how telehealth went this morning and today's presentation. So if you can, just click on the link that Kevin has just sent out for a brief few seconds, and we really appreciate getting that back. And thanks to everyone for joining us today, and we'll see you next Wednesday, same time, same place. Have a great week. Great, thank you. That was great.